actually get together, even though it is virtual. Okay, I think we can get this party started. Thanks very much for joining us. Thank you for putting your vagina at the top of your to-do list tonight. And welcome to the ultimate guide to pelvic health. My name is Shirley Weir. I'm the founder of Menopause Chicks. And we are joined tonight by the Vagina Coach, Kim Vopni. Hi, Kim.
Hello. Hi, everybody.
Kim is amazing. This is how it's going to go down. I'm going to speak for just a couple of minutes about vaginal moisturizer, because it's something that we get a lot of questions about, and also to recognize the support and partnership that we receive from Pure Pharmacy. So tonight's event is free. It's part of a series of learning opportunities that we are hosting for September is Menopause Awareness Month, and we couldn't possibly host all of these events and educational opportunities if we didn't have the support of our brand partners, which include Vichy Canada, Pure Pharmacy, Ferropro Iron, and healthing.ca, which is the health platform for the National Post newspaper network. So we're very grateful to their support. And I think I'll just dive in. I wanted to spend a couple of minutes. I know Kim's going to mention it in her presentation too, but if you are a member of the Menopause Chicks community, you may have seen that just almost a year ago, as a result of the members in our community asking for another solution to address vaginal dryness and vaginal atrophy, we took your questions and your request to Pure Pharmacy, who compounded using hyaluronic acid and a little bit of vitamin E, this vaginal moisturizer that has been getting rave reviews. We have thousands of women now who have actually used it, continue to use it, reorder it. And I thought tonight, since we are talking about pelvic health, and since the Vagina Coach has actually taught me everything there is to know about pelvic health, I wanted to just go over vaginal dryness and maybe even some of the misconceptions that are associated with it. So I think it's probably well known or well understood that vaginal dryness is an experience for women in postmenopause. What happens is our hormones fluctuate during perimenopause, and then after menopause, after you go 12 months without a period, estrogen goes for a deep dive. And estrogen is the hormone that's responsible for keeping everything juicy: our eyes, our mouth, and our vaginas. And so without that estrogen, women will often experience vaginal dryness or vaginal atrophy. There's a number of different ways that we can address that. And maybe, Kim will go through that in her presentation. But one of the ways, one of the solutions that's available to women, and suffering in silence is not an option, is hyaluronic acid. So that's why that is the main ingredient in this vaginal moisturizer. Hyaluronic acid is a naturally occurring compound. Our bodies produce it on their own up until around, I used to say around age 40, but I learned yesterday from a dermatologist at Vichy Canada that actually starting at age 30, our production of hyaluronic acid starts to decline, and it declines about 10% per decade. And then it goes for a bit more of a dramatic decline after menopause. So you've maybe been to the drugstore, you've maybe glanced down that aisle, you've maybe seen products that might say moisturizer or lubricant, and you might have questions. And I just always encourage everyone to, it's great what it says on the front of the box, but to turn the box around and to read the ingredients. Because what we learned from a number of the women who trialed the moisturizer when we were just getting it off the ground is that there are ingredients that are sometimes put in those drugstore products that are not always beneficial. So if you look at the ingredient list and you see water as the first ingredient, that means that it's mostly water. And I don't know about you, but I've been washing my hands a lot lately. And every time I touch water, I need to moisturize right after. Water is drying. So not always a beneficial ingredient when you're shopping for a vaginal moisturizer. Other things that you might see is glycerin or a derivative, which is sugar essentially, and sometimes that can lead to yeast. And then you might see other ingredients, names that I can't pronounce all the time. And those are often additives and preservatives that are meant to extend the shelf life of the product. We took all of that information, we took it to Pure Pharmacy, to the compounding pharmacists, and they were able to create a product exclusively for menopause chicks that is just hyaluronic acid and a little bit of vitamin E. And so the other thing that I wanted to add to that is it's not exclusively for women in postmenopause. Vaginal dryness, as I've learned from Kim and some of our other health professionals in the last year, can affect women, ironically, who are on the birth control pill, can affect women if they are chronic users of absorbent pads or panty liners, can cause vaginal dryness. Or it might be another health condition. It might be someone who is in postpartum. It might be someone who is going through cancer treatment. So, and then it might be someone like our mother or our grandmother who might not have access to this information and education. So I do want to encourage everyone tonight, as you're learning from Kim Vopni, the Vagina Coach, to also think about the other women in your life who might need this important information. And if we can share it with our daughters and our mothers and grandmothers and sisters, I think that the work that we do can go a long way to ensure that right now, less than 4% of women who experience vaginal dryness are getting treatment. And there's a whole range of reasons why that is. Everything from, women being uninformed, women thinking they're the only one in the world that's experiencing it, so they don't speak up, and physicians not always mentioning it during our health appointments. So that's why it's really important that we can get together on platforms like this with amazing health experts and learn and then pay it forward. So, okay. That's my spiel. Go to purepharmacy.com or moisturizeyourvagina.com and order your vaginal moisturizer. And at the end of tonight's event, both Kim and I have a special offer that we want to share with you. So there we go. Everyone is through the waiting room that I can see. We've got 40 people on the Zoom call. I'll check Facebook in a minute. And without further ado, it is my pleasure to introduce to you someone who has become a very dear friend of mine. But as I mentioned off the top, she has also taught me everything that I currently know about vaginas, vaginal health, and pelvic health. And she is very passionate about moving this conversation forward and helping women put their pelvic health at the top of their to-do list. So Kim, welcome.
Thank you very much. I really appreciate having me.
Take it away.
Yeah, and like Shirley said, I'm really glad that all of you chose to prioritize your pelvic health and join us tonight. So thank you for that. I'm going to get going and share my screen here with everybody so I can get the presentation started.
And if you have questions as we go, just pop them into the chat and we'll host a Q&A at the end.
Yeah, and if there's something like if somebody has a question right away with something and they post it to you, feel free to interrupt. That's totally fine too, because sometimes it's nice to have a bit of sometimes other people have that same question. So anyway, we're talking about pelvic health 101 and how you can prioritize your pelvic health. And a little bit, we need to understand kind of the landscape first in terms of what we're dealing with before we can learn how to address some of the things that may not be working as they should. And I got into this line of work really because I was initially I was afraid of giving birth. I remember my mom talking about childbirth, and she had an episiotomy, and she had, you know, a tummy that wouldn't flatten. She had back pain. She ended up having surgery for incontinence. She had a hysterectomy. She had heavy periods. She had all these things. And I just thought, oh my gosh, like, I don't think I'm going to sign up for that. Thank you very much. And so I grew up thinking that I wasn't going to have children. And I watched my sister-in-law give birth. And that was an introduction to a different way than I had ever seen before. She used midwives. She was in a side-lying birth position. And that sort of inspired me and empowered me. And the following year I was pregnant and was talking to my midwives about what I could do. So I wanted to be as proactive as possible so I could have a different story than my mom. And that's basically how I ended up here. And I didn't intend for it to become a business, but after I gave birth, there were things that I had done that helped me. And there was a product I used that helped me. And I recognized that more people needed to know. I became a distributor for that product, and kind of the rest is history. And some of the first people who I started connecting with, who I didn't even know exist, were pelvic floor physiotherapists. So I'm going to talk about that in my presentation tonight, but they are somebody who I preach from anywhere, scream as loud as I can that every single person with a vulva and a vagina should be seeing one every single year. But they've also been a big collaborator with me in terms of helping me understand and learn, and they've taught me. And so I'm going to share with you what I've learned over the last, it's been 16 years since my first son was born. My God, that's crazy to think about. But anyway, let's carry on here. So, okay, so we're going to talk first about what the pelvic floor is. I'll go through anatomy. We're going to talk about optimal function versus dysfunction. What are some of the common causes of pelvic floor dysfunction? So what the signals are, but then also what that means and what are some of the potential contributors, because sometimes it can be very easy lifestyle changes. We're going to talk about tips for a fit and healthy pelvic floor, which includes a vaginal moisturizer, and key movement partners of the pelvic floor. And then we will go into some questions. So I've got also here I've got lots of props. You can probably see a couple of them behind me too. I have different pelvic models. So I'm going to be pulling out a few things to help illustrate beyond what is on the screen here. But essentially the pelvis is made up of 3 bones. So we have our sacrum here, we have our ilium bones, and at the very base of our sacrum, we have our coccyx, and they're joined at the front here by a joint, the pubic symphysis joint. And then at the back, we have 2 joints here. If anybody's ever heard of SI joint, or if anybody's ever had back pain, these are the SI joint pains, which is a very common contributor to that. The female pelvis is different shapes. So men have a pelvis, men have a pelvic floor as well. But from a female anatomy perspective, ours is wider. We have a wider opening. We have like a wider pelvic outlet. We also have an additional opening. So we have a vagina. We have an additional organ. So there are definitely anatomical differences. So in the illustration on the slide here, you can see kind of that dark shaded area, which is representing the pelvic floor muscles. And here is, so this is a pelvis that's lying on the back. So you can see the anus here. This would be considered the perineal body, which is in between the vagina and the anus. And here's the vulva that we've got the vagina and the urethra here as well. So the attachment points of the pelvic floor are the 2 sit bones here on the side, the pubic joint at the front, and then at the base of our spine, the sacrum, the base of sacrum, sorry, our tailbone. So those are the attachment points. So we're talking about the group of muscles that closes off the pelvic outlet. So here is the bony structure, and this is sort of representative of what's in the diagram there. And the pelvic outlet would be here. So outlet meaning that's where things come out. And we're talking about the group of muscles that closes that space off. So the female pelvis, pelvic floor, as I mentioned in the diagram here, can you see my cursor if I'm scrolling on here?
Yep.
You can. Okay, so here's the pubic joint at the front. People refer to it as a bone, pubic bone, but it is actually an intersection of 2 bones, so it is a joint. And then that sling of muscles, oops, I've lost my cursor. There we go. The sling of muscles here is the pelvic floor, and it attaches, this is a side view, so you can see the tailbone at the back there as well. So it's not one muscle, it is a group. It's 3 layers of muscles. The first 2 layers are focused more on the closure. So you can think of sphincters, and if you think of sneeze pee, which we're going to get into, or incontinence, that would be more the responsibility of the first 2 layers. And then the 3rd layer is more responsible for the organ support. So we have 3 layers of muscles. There's a lot of ligaments. there's connective tissue, there's blood vessels, there's a huge nerve supply. And the functions would be, so again, because of those attachment points that I mentioned earlier, it's attachments to the pelvis and the base of the spine means that the pelvic floor muscles play a role in our pelvic and our spinal stability. They play a role in our continence. So I just talked about the first two layers playing a role in the sphincter control. So we need the ability to distinguish between pee, poo, and fart. And we need to be able to decide if it's a good time for any of those things to come out of us. And right now I don't want any of those things to come out. So I'm going to want the ability to be able to hold that and close those sphincters off. So the pelvic floor plays a direct role in our continence and our decision-making. And the organ support. So bladder, uterus, and rectum, those are the internal organs in the female body, and the pelvic floor plays a role in helping keep those organs up where they're supposed to be, supported where they're supposed to be. And the pelvic floor also plays a role in our sexual response. So super important jobs. And really, most people have never heard of the pelvic floor and the importance of it until there's something going wrong and something that needs to be fixed. And then I hear all the time, well, why didn't anybody tell me about this before? Had I known this, had I been able to do something to prevent it, it would have been so much better. And why didn't anybody mention it before? So that's kind of what our collective mission is. Shirley and I and many other people who I work with, we're trying to get the message out, the education out. So people are more informed. They can ask their healthcare providers, but also seek a variety of opinions. We need a pelvic health village. So it's not just one care provider that's going to be helping us. So from an optimal function perspective, the pelvic floor is the foundation of our core. So if you've ever done anything in a fitness class or read anything about fitness, you will have heard the term core. Everybody's obsessed with core. And that's been ever since I've been in the fitness industry, which is over 20 years now. The core has been a hot ticket item, and it still is. But what has been missing in core fitness or core anatomy, core knowledge is that the pelvic floor is the foundation of the core. So in the image that we have here, you can see the muscles of the pelvic floor. You can see the tailbone and the pubic joint where the attachment points are. Again, there's attachment points on the side, but we can't see that in this diagram. But I want you to see that the transversus abdominis, so that is what people refer to as the corset muscle. So it's the deepest layer of our abdomen or abdominal muscles. And on top of that, there's the breathing diaphragm. And on the back, there are some muscles that run along the spine. They kind of branch out almost along the spine, kind of like a Christmas tree shape, and they're called the multifidus. So those four players make up the inner core unit, or the inner core canister, some people refer to it as, with the pelvic floor being the base. So our core is actually these, I call them the core four. And most core fitness focuses on the outermost abdominals, and sometimes we think about the low back, but most people think of the core as abdominal, like twisting, oblique work, planks, that type of thing. And when we can harness the power of the pelvic floor, when we have the knowledge that it is an integral player, as well as the breath and the relationship between those two, we can generate more power. We can lift heavier. We can move with more freedom. We can overcome things that get in the way, like incontinence and what have you, which we're going to be talking about. So the core four work together as a team, and the breathing diaphragm and the pelvic floor have a synergistic relationship all day long with every single breath that we take. So inhales, the diaphragm comes down, it's drawing air into the body. And in order to get the maximum amount of air into the body, it asks the ribs to expand, it asks the belly to expand, and the pelvic floor also lengthens, or it should. So inhales are about expanding and lengthening and kind of releasing tension. And then on the exhale, the pelvic floor is responsible for contracting and lifting. The transverse draws inwards, and it's kind of a contraction and movement of air out of the body, and the diaphragm moves back up. So that is optimal function. But there are things that can get in the way of that optimal function and then start to contribute to kind of a few annoying things that we're going to be talking about, like incontinence and organ prolapse. And part of the job of the pelvic floor and that inner core unit is to anticipate our movement, or to anticipate what is going to happen. And it's when something within that synergy, within that relationship of the core four breaks down, that anticipatory element is lost. And then that's what can then result in things like potentially stress urinary incontinence, or where the sphincters can't close hard enough, or they can't close in time, or maybe the relationship between the pelvic floor and the diaphragm has been off because of a posture shift. There's all sorts of things that can contribute, which we'll talk a little bit more about now. So the types of pelvic floor dysfunction that are the most common. So this is not an exhaustive list, but this would be the most common. Incontinence would be the one that you probably have heard about the most. And it's actually statistically not the most common. So statistically, they would say, you know, between 1 in 3 women. I think it's a little bit higher than that, but depending also on people who have given birth or not. It doesn't mean that you're immune to it if you have not been pregnant or given birth, but it certainly ups the risk. So stress urinary incontinence occurs when there's some sort of exertion, laughing, coughing, sneezing, jumping, standing up from a chair, downward dog in yoga. It can be all sorts of things that increase intra-abdominal pressure. So intra-abdominal pressure is the pressure in our abdomen that we all have and we all need. It's part of our core stabilization system. But when we don't manage that pressure well, then it means that we may not be able to close those sphincters off in time. It means maybe there's downward pressure on the organs. It can lead to a bunch of different things. But the stress urinary incontinence being the most common that you would hear, sneeze, pee, peasing. And it essentially means that there's an exertion of force, an increase in intra-abdominal pressure that what's underneath that core system can't manage. And so little bits of urine would leak out through the day. Urge incontinence is where there is a sudden overwhelming urge. So you're going about your day and then all of a sudden you feel like you have to go and you have to get to the bathroom urgently. And oftentimes you don't make it. And that is a full release of the bladder. You can have a combination of the two, which would be considered mixed incontinence. Stress incontinence is more common than urge, but I do find, especially in people that I work with, that it is quite common to have both. You can also have fecal incontinence, which is where you would not be able to control the passage of gas or stool. Much less common, but still something that we need to be aware of. And what else would I say on incontinence? Those are the main things, I think. So the next one being pelvic organ prolapse. This one statistically is higher. So one recent study came out which showed that 83% of women at 6 weeks postpartum have some degree of prolapse, and 50% of that 83% have a stage 2 or greater. So I'm going to talk a little bit about what the grades mean. So not everybody has given birth, and you don't have to have given birth or been pregnant to experience pelvic organ prolapse, but childbirth is definitely a risk factor. And right now there is no screening or information given to women ahead of time or after from a postpartum recovery. So most people don't even know they have it because sometimes it's asymptomatic early on. But so we need to really improve that. And afterwards, so now looking more long-term, other studies show that it's about 1 in 2, so 50% of women, just over 50% of women have some degree of prolapse. And a lot of people don't even know they have it because it can be asymptomatic in early stages. So I always bring out a little bit of I've got my sleeve here to kind of give you a mental image of what's happening. So if you can imagine that my sleeve here is the vagina. At the top would be the cervix and the uterus. On the anterior wall, we would have our bladder here, and then this would be the posterior wall of the vagina, and we would have the rectum. And what happens in a prolapse is the one or all of those organs start to either descend into, in the case of the uterus, or bulge into either the front or back wall of the vagina. So a bladder prolapse would be bulging into the anterior wall of the vagina. It's called a bladder prolapse. It can be called an anterior wall prolapse. It could also be called a cystocele. The uterus sits at the top and it can start to descend into the vagina, and it's typically called a uterine prolapse or uterus prolapse. And then the back, we have the rectum. And if the rectum is prolapse, it will bulge into the posterior wall of the vagina. It would be called a posterior wall prolapse or a rectocele. It's not called a rectal prolapse. A rectal prolapse occurs when part of the rectum actually comes out of the anus. So that can actually happen with men as well, whereas these would be exclusive to female anatomy. In terms of grading, there's 4 stages of prolapse, or grades. Early stage prolapse, grade 1, grade 2, is often asymptomatic and most people don't even know they have it, and it's just a slight bulge, and it's usually at least 2 centimeters away from the entrance to the vagina. In a stage 3 prolapse, I'm going to get a different model now. In a stage 3 prolapse, there would be a bulge that would be right at the entrance to the vagina. So people can either feel it or they see it if they look. And a stage 4 prolapse would be where the bulge is actually coming right out of the entrance to the vagina. Now, stage 3 and 4 typically are symptomatic and people will know that they have it. And once it reaches a stage 3 or a stage 4, it's very difficult to reverse that. Stage 1 and stage 2, there is possibility of reversing or reversing it completely, reversing it by a stage and managing it. If the person has the awareness, has the education. So I have a stage 2 rectocele. So my rectum bulges into my vagina. I've had it for, it's about 8 years or so now. And I was symptomatic early on, but with a whole bunch of work and changes along the way, I'm basically asymptomatic now. But I have the knowledge, and so I make choices in my life based on that knowledge so that I can prevent it from getting worse. And that's the missing link I feel with, sorry? Oh, I thought somebody asked something. That's the missing link with regards to pelvic health, and why I'm screaming from the rooftops so loudly, because we need more awareness, we need more screening. A vaginal vault prolapse can occur when the uterus has been taken out. So in the case of a hysterectomy, what happens is that the uterus is kind of like a keystone organ. And when that is removed, then everything else needs to be resuspended artificially. And there's a bit of a gap, there's a space where the uterus used to be. And again, without the knowledge that the person is at an increased risk of other organs prolapsing after a hysterectomy, people will often go back to doing what they were doing before. And it's not to say that the activity itself is bad, but their strategy may not be ideal. And if they're not managing that pressure well, then they could be at risk of other things moving and descending into that space where the uterus used to be. Pelvic pain is another one. So pain there's many, many different facets, and I've only listed a very, very superficial list here, but SPD is more common, I would say, in pregnancy, where the symphysis pubis, so that pubic joint at the front there, can become quite painful. You can have tailbone pain or coccyx pain as well. And sometimes that can be from posture or from sitting, could be from falls on the tailbone, could be from car accidents. Dyspareunia would be pain with sex. So there's no pain thinking about it, or there's no pain until the penetration is starting to happen. And that is actually very treatable with regards to pelvic floor physiotherapists, working with the pelvic floor physio. And then vaginismus, which can be more, it's kind of pain in and around the area. Sometimes it's not always explainable. So that's, again, very high level. It goes deeper with regards to pain syndromes, I would suggest, but everybody should see a pelvic floor physical therapist, but especially if you are dealing with pain, and especially if that pain is relating to sexual activity, there's a lot of very successful treatments that are available for you. So contributing factors to pelvic floor dysfunction, PFD is pelvic floor dysfunction, not personal flotation device. So you can have poor posture, and this is a big one. And I see this with pretty much every single person that I'm working with. And it's the number one thing that always the place that I start, is looking at how people hold themselves through the day. So a neutral pelvis, you probably have heard the term neutral pelvis, and people, again, especially in fitness classes, have different interpretations of what neutral would be. A neutral pelvis is where the 2 hip bones, so if you put your hands on your hip and you feel those 2 kind of bony points at the front, that's here, your ASIS, they're technically called. And this is, again, is your pubic joint here. When those 3 points are in the same plane, that would be considered a neutral pelvis. So for those of you that are sitting right now, if you're sitting watching this, I want you to sit down on your chair, and ideally it's a harder surface. If you're on a couch, it's a little bit harder to feel, but I want you to put your fingertips on your pubic joint and kind of guide it forward, almost like you're asking it to tip forward. And what that does is it puts your vulva on the surface of the chair, the surface of whatever it is that you're sitting on. And I'm going to turn it around this way so that you can see that the tailbone is now free. So when I'm in a neutral pelvis, there is nothing, the chair or floor or whatever I'm sitting on is not in contact with my tailbone. So when we talk about tailbone pain or pelvic pain or SI joint pain, a lot of it can be resolved actually just by changing how you hold your pelvis through the day. So this would be considered neutral pelvis. And it's not to say that you can't slouch or that you can't take a break and you can't tuck your pelvis. You absolutely can and you absolutely should. We do need some rest. But the majority of the time, for the majority of your day, you want to spend more time in neutral. And why that's important, one, if you can see, this is the bladder here and the uterus. We have the element of support from our pubic joint when we are in neutral pelvis. See, the bladder's kind of resting on that pubic joint right there. And then the uterus rests on top of that. So if I spend more time sitting in a tucked position, now what happens is I've lost that bony support. Things start to tip a little bit backwards. Muscles and ligaments are there to hold and play a role in that. But we want to take advantage of all of the support mechanisms that we have. So fixing how you hold your pelvis can be a really, really good one. The other thing to consider is, here's the bony pelvis now. So here's the sacrum, the tailbone, the two sit bones in that pubic joint. I'm going to flip it around this way so it's upside down. This is as if somebody was lying on their back. This is the pelvic outlet, and this is an attachment point of the pelvic floor. And this is the base of the sacrum, which is a joint, as we talked about. And we have a little bit of movement in this joint. We don't have a whole heck of a lot, but we do have some. And so if I stand or sit, especially if I'm sitting and there's something against my sacrum, it actually starts to tuck that tailbone more underneath us and narrows the space or the distance between the tailbone and the pubic joint. And what happens to the group of muscles that likes actually to be at its optimal resting length here, when it's tucked, it starts to kind of sag a little bit. And then over time, the body adapts and starts to shorten that group of muscles, and it holds on to more tension. And why that's important is because a muscle that is partially contracted or in a shortened state and not at its optimal resting length can't generate as much force. So when things like intra-abdominal pressure, like laugh and cough and sneeze or jump happen, this muscle has already used some of its force opportunity or potential. So when it needs to counteract this sneeze, it's already partially used its force, so it doesn't have as much. And because it's been short and tight all day, it's tired. And so it kind of, it can't quite respond appropriately. So we want to sit and stand and move in ways where our pelvic floor stays at its optimal resting length so that it can contract fully and relax fully rather than being partially contracted and not having much force potential left. Part of what also happens when we have been holding ourselves in poor posture is our glutes, our big juicy glute muscles start to become inhibited. If you've ever looked at new moms, especially, if you look at their backsides, a lot of new moms have very flat bottoms. And part of it is because of the postural adaptations that have happened in pregnancy and the resulting inhibition of the glutes. So the glute muscles would be, the big glute muscles would be here. And they play a role in helping keep that sacrum out from underneath us, preventing it from tucking under. So if we're sitting and standing tucked, we lose some of the power generation of our glutes, and it also then loses its ability to help keep that sacrum pulled out from under us. So how you hold your pelvis matters, and you really want to focus on working your glutes, which I'm going to get to that in a later slide as well. So weak glutes can contribute to, but they can also be a result of how you hold your pelvis. Pregnancy and childbirth, I would say those would probably be the two number one things in terms of contributing or increasing your risk of developing pelvic floor dysfunction. Falls and accidents. So I always ask people if they've ever fallen on their tailbone. a lot of people who may have been horseback riders or skiers or snowboarders, people who've maybe done rollerblading back in the day. Lots of people have had falls when they really think about it. And sometimes that can jar that joint or potentially fracture it, which then, because that's an attachment point to the pelvic floor muscles, it directly influences their contractile force and the balance between the two sides. BMI higher than 25. So when you have additional weight placed on the pelvic floor that you need to manage, even in pregnancy. So as the baby grows, we have additional weight on the pelvic floor. That is a load that over time can be more difficult to manage. Menopause. So the hormonal fluctuations, which Shirley was talking about earlier. Oftentimes there have been signs and sort of signals along the way, and either people have chosen to ignore them or they didn't necessarily know that they were tied to the pelvic floor. And then once they reach menopause and the hormones have declined, then it kind of ramps up the symptoms. And usually then people are like, okay, I really have to address this now. And typically I believe there's a stat that shows it's about 6.5 to 7 years before a woman will seek help. So usually they have been ignoring or not paying attention, or I'll do it later for 6 to 7 years. And oftentimes when they hit menopause, that's when they're like, okay, I got to do something now. I can't ignore it any longer. Contributing factor could also be overuse or underuse. So people who have very heavy lifting jobs, there can sometimes be one, you've got the weight, but also an overuse. It could also come into certain types of exercise. And then you can have underuse, where people who don't exercise or don't move in varied ways, or who sit for the majority of the day, that would contribute to more atrophy. Whereas the other usually contributes to more hypertone, so overactive pelvic floor muscles. Chronic coughing and constipation being a huge one. So there's, again, one of the main things that I talk about with clients is how many times a day do they poop? Do they strain to poop? What's their diet like? What's their hydration like? We have to optimize our poop, because every time we sit down on the toilet, if we are straining, we are putting downward pressure on the pelvic floor. And if we don't have a prolapse already, the chances of one developing are very high. And if we do have one, the chances of it worsening because of constipation is also very high. So get your poop under control. Nerve damage can actually come from sometimes from constipation, but it could come from surgery. It could come from falls on the tailbone. It could come from pregnancy and childbirth. There's lots of reasons why there could potentially be nerve damage, and nerves are what innervate our muscles and tell them what to do. So if we have some nerve damage, it could interfere with the ability of our pelvic floor muscles to do their jobs. And poor elimination habits. So constipation being one of those, but also peeing just in case is an example. So a lot of women, especially, and I find that this develops quite early on, usually right after they've given birth and they're a new mom, where they're, they have a brand new baby, they're going out in public and they're like, oh, I don't want to have to go in the bathroom. So I'm just not going to drink, or I'm going to pee now before I leave. And then they start going to exercise class and I don't want to leak. So I'm going to pee just in case just before I go to my exercise class so I don't leak, or because I don't want to have to feel like I have to go to the bathroom and get that overwhelming urge. So now I'm just not going to drink water. So those are kind of some things that can contribute to poor elimination habits. Delaying the urge to pee or poo can also contribute to poor elimination habits as well. So we have to get our poop under control, and we have to pee. I like people to use a bladder diary and start to track how often they pee, what volume of pee comes out of them, what foods might be contributing. So drink or hard food, and start to pay attention to how often they're going. And a lot of people, when they really pay attention to it, they notice they're going every, half an hour to an hour. And normal voiding for pee would be considered every 2.5 to 4 hours. And ideally, we're drinking water consistently through the day so that we're staying hydrated. Another thing that when people think, well, I'm not going to drink any water, I don't want to have to pee, that leads to dehydration and concentrated urine, which actually signals the bladder to go more often. So that results in them going more frequently. And then they start to set the bladder up to think it needs to go when it's half full rather than completely full. And they're moving outside of that 2.5 to 4 hour window. And they're more like, 1.5, 1 hour, 30 minutes. And they're waking up multiple times in the evening to pee as well. So in terms of what we can do to optimize our pelvic floor health, everything that I've kind of talked about now, we want to look at how we're holding our pelvis through the day and spend more time in neutral. And if you go to my YouTube channel, I have a posture video on there that you can take a peek at. And I'm also going to, next thing is I'm talking about the core breath. There's also a core breath video there for you. So neutral pelvis will give the muscles the opportunity to have their full capacity of contractile force to respond to that intra-abdominal pressure. But just by moving into neutral doesn't mean that that's going to solve all your problems. We still need to train that pelvic floor, that group of muscles, to respond at the appropriate time and also develop enough strength and endurance. So we can use Kegel exercises. Kegels are I also call it the core breath. So again, on my YouTube channel, you can look at the core breath video. Kegels are often prescribed, but they're very rarely taught. And research has shown that over 50% of women are doing them incorrectly. And recently, actually, the Society of Obstetricians and Gynecologists is putting out new parameters in terms of improving the referral of Kegels. So we can no longer just say, make sure you're doing your Kegels or go home and do your Kegels to fix this problem. There needs to be an assessment component. And that's where I recommend that assessment happens with the pelvic floor physical therapist or physiotherapist if you're in Canada, as opposed to a doctor. So I'll jump ahead here and talk about pelvic floor physio now. So pelvic floor physiotherapists are physiotherapists with additional training in the pelvic floor, and they are licensed to go beyond the introitus, meaning the entrance to the vagina. So they are licensed to treat internally and assess internally. And they, in my opinion, are the gold standard in terms of having an assessment, but also you learning how to do a Kegel. So I use as much visualization as I can. I use some muscle testing and kind of visual stuff when I'm working with clients one-on-one, but I'm not trained or licensed to assess internally. So I'm always referring out to a pelvic floor physio to handle that piece. And they use gloved fingers to assess the external genitalia as well as the internal genitalia. I also have some videos on my YouTube channel about what happens in a pelvic floor physio assessment. And Shirley also has filmed her assessment. So I think that is super, super valuable, because sometimes people, when they first learn, they think, I'm not too sure I want to go. People have an image of PAP exams and uncomfortable speculums, and it can be quite fearful. And if there's been any trauma in the past, then that can be extra fearful. So I think it's important that we have resources like Shirley sharing her experience and other visuals to help people understand what happens. It's very, very different from speculum. It's about an hour long. It's not a 7-minute quick appointment. And people walk away with an unbelievable newfound knowledge of their body. And they'll often say, I can't believe I'm 49 or 52 or 35 or whatever, and I've never known this about my body, or nobody's ever told me about this before. So it really, really, in my opinion, is one of the most underused women's health resources that we have. And I recommend that every single person, even if you've never been pregnant, even if you've never given birth before, that you see one every single year. Just like we see a dentist if we don't have a toothache. We've been conditioned to go to the dentist every single year to get a checkup, to have an assessment, to have a screening and a cleaning and a treatment. And then you might have a cavity here, we should take care of this. They're keeping us one step ahead of the game. Whereas pelvic floor physio, they're basically doing the same thing except for our pelvis. They are the experts. They can see what we can't see. They can feel what we might not be able to feel, and really play an incredible role in terms of screening and optimizing our pelvic floor health, or screening for pelvic floor dysfunction so we can optimize it. So the core breath or Kegel exercises, I'm not going to go through the whole thing here. Please go to YouTube and watch that. Also, if you're on Instagram, I have an IGTV channel where I've got lots of videos on how to do Kegel exercises. And I invite you to do that and follow along and use the different cues that I share. But what I want you to know is that Kegels are not just a squeeze. They're not a squeeze the heck out of your vagina and that's a Kegel exercise. It's a balance between a contract and a lift and a letting go. And most people aren't even aware that it should lift, and they're definitely not aware that it should let go. So all the emphasis is placed on squeeze, squeeze, squeeze. And most people are using either their inner thighs or their glute muscles to do what they think of as a pelvic floor contraction. So when you're doing one, ideally, one of the cues I have is a sip a smoothie through a straw with the vagina. And if you can imagine that you're sitting on your chair where you are right now, imagine there's a smoothie there, and you're going to contract on the exhalation. So as you breathe out, you would allow the edges to come together and pull up, almost like you're sipping a smoothie or a milkshake through a straw with your vagina, and then you let that go. So it goes more in detail in the video. I don't want to take up too much time here, but optimize how you do Kegels and make sure you develop a Kegel lifestyle. They are not a quick fix. They are something that we should be incorporating into our daily life. And I have a 3C approach, which is Kegels work when they're done correctly, when they're done coordinated with movement, and when they're done consistently. And by that, I mean, sitting at every red light or doing Kegels while you brush your teeth is better than nothing. If you're doing them correctly, that's a good step. But most of the time, things like leaking or descent of organs doesn't happen when we're sitting at every red light, sitting in a chair. It happens maybe when we stand up from a chair or when we're lifting a weight in fitness class. So we need to train our pelvic floor in movement, in lifting, when we're exerting a force, so that we're kind of reminding it what it needs to do and train it to be able to manage those increased loads. Strong glutes. So I talked about that a little bit in the last slide as well. The glutes can become inhibited if we have poor posture, and we need to build those back up to help us get back to that neutral pelvis. Squats are a great exercise. Bridge exercise. I really like hip thrusts, which are kind of like a bridge with a weight on top. Standing hip extensions. There's lots of different ways to work your glutes. Also walking uphill. If there's one exercise that every single person should do, they should go for a walk every single day, and ideally one with a bit of hills. And that will really help your pelvic floor. It'll help the length of your legs, meaning hamstring length and calf length, and it will also help work your glutes. Potty posture. So this is an image of me on a toilet, and I have the squatty potty. So if you haven't heard of the squatty potty, I think most of the world now has, but if you haven't, Google squatty potty, and you'll see, I think, one of the most viral videos of all time, which is the soft serve ice cream. And you'll never look at soft serve ice cream the same way, but essentially it shows that there's a muscle that sort of kinks our rectum. So if you can imagine this is the rectum, there's a muscle, a puborectalis muscle that kind of keeps a bit of a kink in there so that we don't have poop coming out when we don't want to. And when we sit down to poo, if we can elevate our knees up above our pelvis, it actually unkinks that muscle. So it facilitates the passage or the removal of waste from our body. It makes it easier. So especially if you have organ prolapse or pelvic floor dysfunction already, or if you're dealing with constipation, it's a must, in my opinion. It doesn't have to be the squatty potty. It could be books. It could be a suitcase if you're traveling. It could be a waste paper basket turned upside down. Whatever you can use to get your your knees up higher than your hips or your pelvis will help optimize that. And also, even if you're peeing, so I don't actually recommend that you put your feet up if you're going pee. This is for poop. If you're going pee, think more of what men do. They kind of sit down and they spread their legs a little, and then they usually lean forward. So I recommend that you sit down. You don't really have to widen your legs per se, but lean forward and rest the backs of your arms on the tops of your thighs. And that helps you untuck your pelvis. So a lot of people, when I was talking about neutral pelvis, if we're walking around and sitting all day with a tucked pelvis, then typically we're also sitting on the toilet with a tucked pelvis. And if that group of muscles is in that short, tight state, that's going to make it harder to get things out. We need that group of muscles to relax so that these muscles up above can contract to move waste out of our body. So when we sit in a tucked position, it helps, or it makes it harder for those muscles to get stuff out. So make sure you sit untucked. Dietary habits. So again, if you're restricting fluids, that can concentrate your urine, which can lead to it irritating your bladder. If you're not drinking water, that's also going to contribute to constipation. There are other foods, artificial sweeteners, chocolate, wine, caffeine, lots of things can irritate the bladder. Those are the most common, but if you have food sensitivities, gluten, dairy, anything that's contributing to inflammation in your body, that can also trigger constipation or diarrhea, or sometimes irritating the bladder as well. So you want to get your gut optimized. You want to reduce inflammation in the body and make sure that you're eating foods that are good for your body. I talked about pelvic floor physio, move in varied ways. So we now sit as a society, we sit a lot and we aren't moving as much as we used to. And typically what happens is, to make up for the fact that we've been sitting all day, we go to the gym for an hour. And fitness is becoming harder and harder and harder and more intense every single year. There's something that's, you know, harder than it was last year. And we need harder to make up for the fact that we sit so much more. And the combination between the two is really quite disastrous to the pelvic floor. So we have deconditioned, short, tight muscles that are going to the gym and now doing very hard, explosive movement, and they're not able to manage the loads that are placed upon it from heavy lifting or jumping or whatever it is. So we need to move more throughout the day so that we can get the pelvic floor at its optimal resting length. We can reduce tension and train it again to respond to the different loads of fitness and progress back to those things. It's not saying you have to avoid high intensity activity, absolutely not. But we need to make sure that we have a pelvis that's optimized and a core that's optimized to manage the loads. And if you have leaking or pain or feelings of heaviness or pressure in fitness classes, that's a great signal to listen to and pay attention. And not that you have to avoid it, but scale back, work with the pelvic floor physio, work on retraining that system, and then progress back to that activity. And chances are you'll go back stronger. You'll go back and be able to lift heavier or run faster or whatever it is. And then moisturize your vagina. So we talked about that already, but I've actually started myself. So I'm 49. It's been 2 months now since I have had a period. So I'm on, who knows, maybe I'm on track. We'll see what happens in a year. But knowing even before that happened, I think it's probably been about 8 months or so that I've been using the vaginal moisturizer, and I use it with the plunger. I find that I can get it in better when I use the plunger. So I put some into the plunger and I put it up in my vagina, and I use it probably about twice a week. And what I love is that it's, even if I feel like I have a little bit of irritation, I find that it's quite soothing, and I wake up the next day and that irritation is not there. But also I'm being proactive. I don't want to get to the point where I have a problem that needs to be fixed. My ideal is to try to avoid the problem developing in the first place. So I highly, highly recommend that you do the same. So finishing up here, some key movement partners. So if you're thinking about exercise and how to bring the pelvic floor into movement, the bridge exercise is one of them that I talked about. And when you're doing the bridge, you can also add a ball or a block or a cushion in between your thighs. And that will innervate the adductors or your inner thighs, which then kind of translates up the chain almost and innervates the pelvic floor. So that can sometimes work against some people, because if people overuse their inner thighs thinking that they're doing pelvic floor exercise, that can sometimes be something that we need to actually lengthen a little bit more. But typically when we coordinate it with another movement, such as a bridge, we get the benefit of the glute activation. We get some innervation from the adductors. And what I like about this pose is, especially if we have prolapse, we get some inversion. It can help kind of offload the pelvic floor, and even putting a block under your bum in this one and holding yourself up there or resting on the block just can help offload that pelvic floor if you are dealing with symptoms at the end of a day. Another key movement partner would be your transversus abdominis. So when I talked earlier about the core four, the transversus is the deepest layer, the deepest abdominal muscle. And when we contract and lift the pelvic floor, so this would be an inhale and expand and an exhale and contract, what happens is the deep abdominal muscles co-contract. So the in-breaths, there's an expansion of the belly outwards, there's an expansion and lengthening of the pelvic floor. And then when we exhale and do our Kegel exercise, so think about sipping that smoothie through a straw, there's a drawing together of the edges and a lifting up. And what happens is it initiates a co-contraction of the deep abdominals, the transversus. So this is an engaged core. If somebody says to you in a fitness class, make sure you engage your core, most people think about sucking in or holding in their abdomen and bringing their belly button to their spine. That movement naturally happens when you activate your pelvic floor. So I have a bottom-up philosophy where I engage my core from the pelvic floor first, knowing that it will bring my transversus in with it. And then in-breaths, let that go. Exhales, you engage your core. So when you can work on your transversus abdominis, this is an image of the core breath, the end stage of a core breath. So you'll see that in the video when you do it. inhale, my belly, if you can see my left hand there, it's away from my belly in front. My inhale, my belly would actually touch my hand. And then when I exhale and I engage my pelvic floor, my transversus naturally draws away from my hand. So that's what I'm trying to illustrate there. And finally, the glutes. So I've talked about that at length, helps keep the sacrum out from under the body. It also tensions what's called the thoracolumbar fascia. So if we have any people with back pain, that can, the glute work can really help innervate the fascia around, all around. So thoracolumbar, meaning our thorax up here, and our lumbar being our lumbar spine. And it can be really great in terms of helping with back pain. And one little side note, there was a study done by a Canadian physiotherapist recently, it was about 2 years ago, I believe. And she found in her study that 93% of women who have back pain have some form of pelvic floor dysfunction. So if you are a person who has dealt with back pain, many people have, it's very common. It could be posture related, could be from a fall. There's lots of things that could contribute to it. But if you've never had your pelvic floor addressed, that could be the missing link. Usually we go see chiropractors or massage therapists. We have acupuncture, maybe a regular physiotherapist, or we go to the gym, or we do more core work. But if we're missing that foundation of the core, the pelvic floor, it is so closely tied to back pain and discomfort, and it's the missing link. So keep that in mind next time you have a bit of a backache, and make sure you're checking in with your pelvic floor. So squats and deadlifts are something that I really like for glute work as well. We talked about the bridge. Making sure when you're doing your squats that you are sending your bum back behind you. A lot of people who, if they've been sitting or standing in that tucked position, kind of non-neutral position for the majority of the day, when they stand up in a squat, usually what happens when I ask them to perform a squat, the first thing that happens is they bend their knees and they actually sort of shift forward because their pelvis isn't used to actually extending behind them. So really start to pay attention to how you're performing your squat, and that will up the ante on your pelvic floor exercise, as well as that thoracolumbar fascia in your glutes as well. So my final tip is two things, actually. Pelvic floor physio, just do it. So find and see a pelvic floor physiotherapist. I used to have a list of pelvic floor physios on my site, but there is another more robust list that is more updated than mine was. So I refer everybody there. It's a colleague of mine in Florida, actually. She has a website called Pelvic Guru, and she has an international directory on her site. So I am typically directing people there, and you can search by doctor even, you can search by pelvic floor physical therapist, you can search by fitness professional. So it's a really great resource if you want help finding one. You can also use Google and put in pelvic floor physical or physiotherapist and your city. And there's an increasing number of people who are trained as pelvic floor physios out there. The final thing that I will say is, and Shirley touched on this earlier, but tell other people. Share this information with your friends, with your sisters, with your mom, with your aunts, with anybody else with a vulva and a vagina in your life, your daughters. This conversation needs to happen at much younger ages so that people are set up for preventive health, but also they're informed if something comes up, they know what to do, and it's not as scary, and they can catch it early, and they can overcome these things that really can be quite debilitating in terms of the impact on our health. So mostly with pelvic organ prolapse, I would say that's the one that really affects our mental health the most, but all of them do. They affect our interpersonal relationships, our confidence, our movement. A lot of people end up restricting their movement because of their pelvic floor, and we need movement in our life for all the other amazing health benefits, but our pelvic floor will benefit as well. So please share this information with anybody who you think would benefit. And now let's open it up for some questions.
Thank you. Thanks, Kim. Oh my gosh. Yeah, we've got some questions here. So do you want to stop sharing your screen so we can get the bigger version of you?
Yeah.
I want to start. Can you please, I love that you endorse the pay it forward, share it with everyone. Can you speak to pad math for a second?
Yes. So one of the strategies and something that people accept as just something they need to do now is they wear pads, and more media is telling us that it's just part of being a woman, or, you know, just have them in your gym bag. And, you know, even these people in the commercials are getting younger and younger and younger. It used to be that it was just, you know, the elderly population who would be dealing with this, but it's getting younger and younger. And that's also to say that incontinence can happen to younger people, high level athletes. A lot of young people also experience it. It's not something that's just reserved for aging or people who've been pregnant. But so if you add up the cost of pads, and I did a very, very, very basic, very low level calculation, meaning I looked at what is the cost of somebody wearing one light panty liner for an entire day. And most people are usually changing it once or twice. But if they were just wearing one a day and they buy a package, it was about $30. And so that every month compounded by, you know, what age they are. So if they're 30, 35, 40, and then thinking about what our life expectancy, how many more years could we be living, and we multiply that, and the cost can get up between $20,000 and $50,000, depending on how many pads and what size and type of pad that you might be using in a day. And that is a significant amount, like super significant amount of money. And it's masking the problem. It's not addressing, it's not a solution. They can play a role. And there are some people who, you know, spinal cord injuries, severe nerve damage, there are people, yes, a certain small percentage of the population would need them on an ongoing basis. But the majority of people do not. It's not something you need to accept as just the way it is, or something that you need to live with. And you can save a significant amount of money by addressing the problem. So invest in a pelvic floor physical therapist, which is about $150 for one session. And maybe do that, you know, you might need 2 or 3 sessions, and you'll do that once a year. And you will save a tremendous amount of money, and you'll also be saving the environment. And there are lots of other, there are many companies now who are have reusable underwear. So Isle is one here in Vancouver. Nixwear is another great one. And while I support the reduction from the environment, so they aren't contributing to waste in the environment, which I absolutely love, I also want you to know that those, in my opinion, should be more of a temporary measure. So they're something that you are wearing while you are seeking treatment until you have overcome your problem. They're not something I believe that we should be accepting as that's now we just have to wear protective underwear for the rest of our life.
100%. There you have it. You did not know that when you signed up for a free event tonight that you were actually going to save $50,000. Okay. I've got some detailed questions for you, Kim. One is a pessary. What is it? How do they work? And will a pelvic floor physio help you assess whether or not you need one?
Yes. Pelvic floor physio can absolutely assess if you would benefit from one. Not all physios can fit you for a pessary. So typically right now, especially in BC, there's a few, but not many. Usually you're going to see a urogynecologist or a gynecologist to help fit you. Even a nurse continence advisor can fit you for a pessary. Pessaries can be a really, really great option. And essentially, if anybody has heard of menstrual cups, they could be considered like something similar. Some of them are similar shapes, but pessaries come in a huge number of shapes, sizes. Different ones are more effective for different types of prolapse. A really great website is a colleague of mine in the UK, Inco Stress, INCO stress.co. I think it's .co.uk, but if you just Google Inco Stress, you will find her. So she designed her own product based on her mom, who recognized when she wore a tampon, she didn't leak. And so Gaynor was thinking, well, why is that happening? And she created a silicone pessary type product that would help. Originally, it was designed to help with stress urinary incontinence. And she has since, over the number of years, designed other ones. And she has a huge pessary guide, a fitting guide. She's an amazing resource. And so pessaries it could be a ring shape. It could be a cube shape. It could be, there's an inflatable one. There's all sorts of different shapes and sizes. And it depends on your anatomy, what organ or organs are prolapsing. And I will say that it can take some time to find the right one. So I would say on average, it takes potentially three different trials to find the right fit and the right size. So it does require a little bit of patience, but when you find the right fit and the right one for you, it can really be life-changing. It will eliminate symptoms. Some of them you can have sex with, some of them you can't. Some of them you can leave in for 3 months. Some of them are take in and out every day. There can be sometimes a little bit of erosion of tissue, so you do have to be a little bit careful. And people like elderly people who may not have as much mobility in their body may have a bit more difficulty with them, but they can be a lifesaver for many people.
Thank you. Okay, back to the financials question. This is our pelvic floor physios covered by Extended Medical, and how is their work different from what you do?
Good question. So if you have Extended Medical that covers physiotherapists or physiotherapy treatment, then you have coverage. So they are covered just like regular physiotherapy would be. How I differ is physiotherapists, again, are licensed to assess and treat internally. I am not. Pelvic floor physios are mostly assessing and treating internally, and a portion of their rehab will be prescribing exercise, but they don't necessarily monitor the exercise or make sure people are staying up to it. So sometimes pelvic floor physios will have a kinesiologist or a personal trainer in their clinic who will help manage the movement piece. And that's really similar to what I do. So I handle movement. I look at posture. I look at movement strategies. I help people with their breath. And even though I can't assess internally, I can see things about breath holding or bulging in the abdomen. I can see lots of different things that could potentially be contributors to some of the symptoms that somebody might be having. So I use fitness to activate, or I bring the pelvic floor into fitness to help retrain that anticipatory element of the core of the pelvic floor so that it responds appropriately from a timing perspective and with enough force to meet the demands of the activity. So if you're lifting 10 pounds versus 20 pounds, that could change your ability to manage the pressure. So we have to work gradually to get you up to heavier loads if that's what it is that you want to do. It's called tension to task. We want the pelvic floor to respond based on the task that we are asking it to do. So that's how I help.
Amazing. And you'll notice I'm not using anyone's name just because we're broadcasting to Facebook. So I'm going to keep going. Our next question is about Rectocele. Can a stage 3 to 4 Rectocele be improved or reversed through pelvic floor exercise?
In my opinion, no, not from a reversal perspective. So rectoceles are the hardest to improve. And I really don't know of a lot of people who have ever reversed, or even, well, I know one person who has improved a stage 2 rectocele. So bladder and uterine prolapse respond better to some of the changes we talked about already, and also a technique called hypopressives, which is a specific fitness technique. And so early stage bladder and uterine prolapse can respond really well to hypopressives, whereas rectoceles, just because they are, especially if it's a rectocele that's lower down in the rectum, though you can have one that's higher up, but it's typically more common to have it lower down. Those are just anatomically speaking, and it's kind of lower down compared to the other ones that are up top, I guess is the easiest way to say. So a stage 3 or stage 4 rectocele, you could have an improvement in symptoms. A stage 4, you will not be, I don't believe that you would take it to a stage 3. A stage 3, you could potentially improve to a stage 2 with a lot of, with a really diligent effort. But they do, unfortunately, rectoceles are the one that do take, they either take longer, or really you're not necessarily going to reverse a rectocele, unfortunately.
I'm going to insert my experience in here just for a second. So as you know, I went to my first pelvic floor physio assessment in January of this year, and I went with 0 symptoms. And I think you talked about this on your Instagram yesterday, but I think it would be really good to underscore for everyone on the call tonight about symptomatic versus asymptomatic.
Yeah, so it can depend on the person. A person who's very hyper aware, stage 1 prolapse they may have full-blown symptoms and they can't handle it. It's consuming their life. Whereas somebody who may not have as much body awareness, or maybe just for whatever reason, they just haven't really been paying attention, they could have a stage 2, 3 even, and they're kind of like, well, I felt maybe a little different, but it wasn't that big of a deal, or I just didn't think it was anything. Or so there's symptoms do not indicate the severity. And that can be also when you're working to improve it, one day that the symptoms feel potentially more pronounced doesn't mean that what you did the day before is necessarily the cause. It could be the amount of time you're sitting. It could be how much sleep you had. It could be how much stress you've had. It could be what you ate. There's so many different contributing factors that we need our symptoms to be guides, but we can't be hung up on, oh my God, I've got symptoms today and I can't do this. But again, on the flip side, there are other people who have none. And that's part of the reason why I promote pelvic floor physio, is because when we can catch it at an earlier stage 1 or stage 2, we have such an opportunity to make improvements, especially with bladder and uterine prolapse, and potentially reverse it. Whereas if we aren't getting screened, then all of a sudden we have, one day we wipe and there's a bulge, or we see a bulge, or it hurts when we have penetrative sex or something. And then you're thinking, oh my gosh. And then it's not that it's ever too late, but it's a steeper hill to climb at that point.
Thank you. I don't even know if I finished my full thought there. I went with no symptoms and discovered that I have a stage 2, 3 bladder prolapse and a rectocele. So it was like, I thought I was being proactive, which I encourage everyone to be. And yet I learned so much through that, initial assessment. I want everyone to see a pelvic floor physiotherapist in 2020. You still have time.
Yes.
Okay, I have a question. It's a bit long here, but it has to do with vaginal dryness and vaginal atrophy and experiencing a little bit of blood during sex. And what would be your advice to this individual?
So first thing would be vaginal moisturizer. So the hyaluronic acid plays a role in healing already irritated or dry tissue, but also then being able to increase the moisture retention so that it doesn't take very long. It can be a matter of days, really. So that would be the first thing. See a pelvic floor physio just to rule out anything else. So there are sometimes conditions, like one of them that's, I wouldn't say it's uber common, but lichen sclerosis is one where the tissue can start to become tight and thin, and that can oftentimes, every time somebody has sex, they can experience small tears or irritation. And so again, seeing a pelvic floor physio, you can help keep that in check and make sure you're screening for it. So those would be the 2 things first that I would recommend. And also trying different lubricants. So lubricants and moisturizers are different. And moisturizers are typically, most recommend that you put them in at night so that you're sleeping and you're lying down and they're doing the work at night. And then the next day, if you're having sex, then you want to have also a lubricant that will help at that moment as well. So lots of different lubricants. Again, looking at the ingredients, you want to have ones that don't have the glycerin, that are water-based. Ideally, there's one called Sliquid Organics that I really like. There's another one called Yes Personal Lubricants that I like. There's a few good ones out there, but those would be kind of the 3 main things that I would recommend.
That's great. Yeah. And I think the light bulb moment for me was that, we say the word moisturizer, like it's almost like a marketing term. And the reality is we're giving back our body that hyaluronic acid that it used to make on its own.
Yeah.
And I think that's
kind of like, exactly. It's kind of like hormone replacement but it's not hormonal. Our body doesn't produce as much of this substance anymore. So let's supplement with it.
When we were initially trialing it, I was like, oh, what if it takes weeks or months for it to work? And like you said, some women are experiencing, because our body's just really thirsty, for lack of a better word, thirsty for the hyaluronic acid that it used to have. So
yeah, exactly.
Great way to explain it. Thank you. Okay, what is next? POP, pelvic organ prolapse. Does it cause incontinence?
Not always, and sometimes it can actually mask incontinence. So if you have a bulge in the vagina, it can sometimes actually create some pressure against the urethra. So sometimes people who have prolapse don't have incontinence. And especially if they have it surgically repaired, they end up having incontinence afterwards because they've removed that bulge that was actually contributing to a little bit of pressure against the urethra. So there can be, but it's not usually, like from a bladder prolapse perspective, let's say, there can be some incontinence. So you could have a combination of the two. And it could also be like, some people notice that when they sit down to pee, they feel like they have to go, but then when they sit down, nothing comes out. And it takes a long time for things to get started. And that could be partly non-relaxing pelvic floor muscles, but it could also be because there's that little bulge, that pocket in the vagina where bits of urine can get trapped. So they either have a difficulty starting the flow of urine, or they may notice that they pee and then they stand up and then they're like, oh, wait, there's still a little bit left. And then they have to sit back down because maybe what was in that little pocket as they stood up kind of shifted and came back out again. So prolapse doesn't mean that you will have incontinence. Yes, you can experience it, but not always.
Okay, thank you. We have a question about whether or not localized estrogen can be used at the same time as hyaluronic acid. The answer is yes. So one of the options there's many options for keeping your vagina moist and healthy. One of them is to practice regular pelvic floor exercises. One is to have lots of sex and lots of orgasms, keeps the blood flowing to the pelvic area. One effective way that requires a prescription from your doctor is localized estrogen. And then the hyaluronic acid moisturizer is a non-prescription, non-hormonal option. What we've found is that many women are using them at the same time, because estrogen therapy does take 3 or 4 months to start working. And you were probably even longer without estrogen. You may have gone like a whole year before you actually did something about it. So it's going to take a while for the localized estrogen therapy to work. And the hyaluronic acid can speed that up. So hopefully that answered your question. Thanks for the resource. pelvicguru.com is the website that Kim mentioned for searching for a pelvic floor physiotherapist in your area. And it's North American, Kim?
Yeah, it's international, actually.
Awesome.
Yeah.
Okay, and the pessary question we answered, and the rectocele. Is a tilted uterus the same thing as a prolapse?
They don't typically consider it. Usually they'll call it a retroverted uterus. So they don't necessarily consider it a prolapse because it's not necessarily descending into the vagina. But it is, and sometimes that's just the person's anatomy. Sometimes if there's a rectocele and the bulge happens, there's a little bit less support there. So sometimes that can contribute to the uterus tilting a little bit backwards, but it's not typically considered a prolapse per se. And I just saw one comment. I didn't see the whole thing come up, but somebody I think just commented saying, unfortunately, there's nobody in, and that's all that I saw. But I'm wondering if maybe that person went to Pelvic Guru and didn't find a physio that was listed there. That list is not exhaustive. That every physio in the entire world is not listed on that list. So if you can find one, they're fantastic. But remember to Google and either your city or your county or your province or whatever it is, and see if there's somebody who's maybe around. And some people may have to travel a little bit, but if there's nobody on that list, don't say, oh, well, then there's nobody for me.
And 2 great things about that too. First of all, this person is in Regina. I'm sure we can probably find you someone in Regina or Saskatchewan. And one of the silver linings of COVID actually is that many pelvic floor physios are offering virtual appointments.
Yeah.
And I mean, I know that we talk about them doing an internal, but I found the internal part of my pelvic floor physio experience was a small piece of the whole appointment. Most of it is about conversation and education. And yes, there was an internal, but you can see a pelvic floor physio and at least get the ball rolling by meeting someone online.
Totally. And you can, if you're in Canada, for the people who are in Canada on the call, pelvichealthsolutions.ca is also another directory. It's not as robust, but there are sometimes, specifically to Canada, there may be more Canadian ones there who may not be listed on the Pelvic Guru one, but you can try that one as well.
Awesome. Okay. Wow. Now the questions are starting to roll in faster. Is taking a bath bad for prolapses?
No.
Do you want to comment on any yoga or yoga practices and how they might help us?
Yeah, I believe in having a variety of exercise and movement practices. People think of yoga as being gentle, but there was a study on intra-abdominal pressure, because for a while like when I very first started this, there really wasn't a whole ton of research on pelvic health or on the abdominal wall. And at the time, everybody was getting concerned about diastasis recti, which is the migration of the rectus muscles away from the midline and the thinning of that connective tissue. And it was like, don't do crunches, don't do planks, don't do twists, don't do this, don't do da-da-da, because it increases intra-abdominal pressure. And then you might get a prolapse, and if you have a prolapse, it's going to make that worse. And so everybody was up in arms about intra-abdominal pressure. But then more and more people started questioning that. And thankfully some research was done, and they looked at a bunch of different movements, and standing up from a chair has more intra-abdominal pressure than a crunch exercise. I think it was either just above or the same. I can't remember 100% on that, but also downward dog. So downward dog is a yoga position. And again, we think of yoga as being so gentle, but that movement has a fairly high increase in intra-abdominal pressure. So that doesn't mean that they are bad. It just means that we need to look at how a person is doing a specific activity. How does that person execute their downward dog? How does that person execute the crunch or the standing up from the chair? And then if there are symptoms, or if we notice that there's a strategy that's not ideal, then we need to look at how we can do that differently. So it really comes down to it's quite individualized. And we can't blanket statement say Pilates is bad, CrossFit is bad, yoga is better, or whatever. It's choose what do you like to do? What brings you joy? What do you want to do? And that's going to be what you should do, really, or what you're going to participate more in. And then if you notice symptoms, or if you want to make sure that you can make it more effective, work with a personal trainer who's trained in this, work with a pelvic floor physiotherapist, and understand your strategy in those movements. And then look at, if you feel symptoms or if you notice leaking, does that mean you have to stop it? Maybe, but first let's see, how could we do it differently? Maybe it's when you run, maybe you run less, maybe you run with a different stride, maybe you run more uphill and walk downhill, maybe you run 2 minutes and walk 5 minutes. Like, there's lots of different ways to vary it to make it more suitable for you. And then as you're working to retrain the system, then that exercise could, eventually you'll go back to running, or you'll go back to jumping or downward dog or whatever it is. So I love yoga for many different reasons, but there are certain positions in there that not everybody can do the same. And people need to have kind of a more individualized approach to any type of exercise that they do.
That's amazing information. And follow the Vagina Coach on Instagram and YouTube, because she has so many tips there on a regular daily basis. And she'll get inside your head like she's got inside mine. Like tonight, for example, just thinking about walking uphill. Like, I'm going to think of you now every time I walk up a hill. I learn something every time I speak with you, Kim. It's amazing. We have one more question. I realize we are getting very close to 6:30 or 9:30 in the East. So thank you for staying with us. We have just a couple of closing messages. So let's do this last question. Is it beneficial to stop peeing midstream?
No. If you do it once in a blue moon to test if you can stop the flow of urine, sure, give it a try and see how you do. But it's a test to identify if you can close those fingers, if you can recruit the muscles to stop the flow of urine. You do it once, you see if you can, and then you stop. Because if we are consistently interrupting that flow, it can actually contribute to infection, but it also interrupts the kind of the mind body, the brain bladder connection. And it can result in other challenges down the road, essentially. So no, it's not an exercise that should be performed while you're on the toilet. You could do it as a test every now and then, but it's reserved. You contract and relax your pelvic floor ideally outside of the bathroom.
Thank you.
During sex, maybe during exercise. Those are good places to activate your pelvic floor.
Awesome. Awesome. Okay. We have a couple of offers to tell you about. So I would like to thank everyone for staying with us tonight. Thank you for putting your pelvic health at the top of your to-do list. Do you want to go first, Kim?
Yeah, sure. I run a 28-day, it's called the Buff Muff Challenge, and it happens on the first Tuesday of every month. And it is an app-based program that is a series of exercises. So every day you get a reminder to log in, to open up the app, and you get 5 exercises as a pelvic floor fitness workout. And it's very much whole body. So you're not going to be sitting in a chair looking at your app, contracting and relaxing your pelvic floor. You're going to be upright and you're going to be moving and you're going to be building your glutes and you're going to be lengthening the things that need to be lengthened and strengthening what needs to be strengthened over 4 weeks. And I'd like to give everybody an opportunity to save $10. So it's only $27, but you can save $10 with the code Menopause Chicks. And you go to vaginacoach.com/buffmuff. And the next challenge starts October 6th. And I've had, it's about 1,800 people have gone through. So since I first launched the challenge, about 1,800 people have gone through the challenge. 100% of people will recommend it to a friend. And the majority of people are noticing a reduction or elimination of symptoms, often by week 2. So 14 days in, sometimes even as soon as 1 day or 1 weekend, but it more commonly is around 2 weeks. So it really is when I was talking about retraining that anticipatory element of the core, making sure that the timing is there and also the ability to use enough force to withstand leaks, reduce organ prolapse, the pressure of organ prolapse, back pain, those types of things. So I invite you all to join us on the next one. And again, it starts October 6th, vaginacoach.com/buffmuff, and use code Menopause Chicks, all lowercase.
But thank you very much. We will include all of that information with the email and the replay tomorrow. The chat is filling up with people on the call tonight who are already a part of your challenge. And I will just add that, you are going, if you haven't already, you're going to go see a pelvic floor physio. They are going to give you some exercises or some strategies. And it's really helpful to have the app as a reminder. If you need an accountability partner, Kim is the best. So I would recommend that you do that. So we'll include that information on the email tomorrow. I would also like to extend an offer from Pure Pharmacy. So if you go to purepharmacy.com/menopause chicks, the first item that you will see there is the vaginal moisturizer. The second item is actually a lubricant called Good Clean Love. And that we've selected that there because of it won't change the pH level of your vagina, and it's got the minimal amount of ingredients. And yes, you do want to use a lubricant for fun and pleasure, and use the moisturizer for short-term and long-term vaginal health. So the code for saving 15% this month for those of you that have signed up for this event tonight is Pure Online 15. If you already went on and ordered, which I think someone did, just send me a message and we'll extend the offer for your next purchase. So I would like to thank you, Kim. Again, I always learn so much every time I am in your company, but thank you for the effort that you and the time that you put into tonight's presentation and for sharing your expertise with us. I know that everyone is really, really pleased.
Thank you.
Stop talking.
I really appreciate it.
Again. Thank you. September is Menopause Awareness Month. If you are interested, we're hosting 2 events tomorrow. One is Do I Need to Have My Hormones Tested with Dr. Anna Garrett. It's a free event. It's in the afternoon at, I think it starts at 1 p.m. Pacific time, but if you sign up, go to mybestmidlife.ca. You'll see all of our events there. And if you sign up, I'll be happy to send you the replay. And then tomorrow night, we're actually hosting an encore an encore event with my own doctor, Dr. Julie Dernan. And it's the ultimate guide to perimenopause, menopause, and beyond. And it's really, really good. So, yeah, so sign up for that and have a great evening, everyone. Thank you so much for joining us.
Thanks, Shirley. Thanks, everybody.